Welcome to Discussions with Dr. G, the show where pathogens quake and nursing brains get a workout. I'm Dr. G, your sarcastic Sherpa upon the microbial mountain. Buckle up as we dive into the weird and wild world of mycobacterial, parasitic, and fungal fighting medications. Spoiler alert, it's itchier and spottier than you may think. Alright, let's kick things off with tuberculosis meds, because nothing says glamorous nursing like a patient hacking up a lung and you trying to remember if it's the orange pea drug or if it's the one that fries your nerves. So the main players here, rifampin, isoniazid, pyrazinamide, and ethambutol, or RIPE for short. You heard me, RIPE. Rifampin, isoniazid, pyrazinamide, and ethambutol. If you're a student, you've probably already got INH and rifampin burned into your brain, but let's break down why you should care. Isoniazid, or INH, is the classic. It's great for both active and latent TB, but it's got a mean streak. Peripheral neuropathy. That's when your nerves start acting up, and it's not just a little tingling. It can get pretty uncomfortable. The reason? INH messes with vitamin B6, so you gotta give pyridoxine, also known as B6, to keep those nerves happy. And of course, you have to worry about hepatotoxicity. The liver is always the unsung hero, or the tragic victim, in pharmacology. If your patient likes to drink or already has liver issues, INH is basically a double whammy. Oh, and don't forget hyperglycemia, rash, fever, the usual party. Rifampin. This one's famous for turning all of your patient's fluids orange. I mean sweat, tears, urine. Suddenly it's pumpkin spice season in July. But seriously, you gotta warn patients or they're gonna think they're dying. Rifampin is also a CYP450 inducer, so it messes with birth control. Warfarin, antiretrovirals. Basically, if it's important, rifampin will lower its levels. Again, the liver. Always the liver. All right, ethambutol and pyrazinamide. This rounds out the group. Ethambutol can mess with vision, so think E for eyes. And pyrazinamide, well, it's not as notorious, but it can still hit the liver and cause joint pain. So as a nurse, you're monitoring liver enzymes, teaching patients not to drink, and making sure they actually finish their meds. No, I felt better, so I stopped. Aloud. TB does not play nice. Moving on to antifungals. And let me just say, amphotericin B, also called amphoterrible, it's called that for a reason. It's like napalm for fungi, and sometimes for your patient's kidneys too. We use it for the big, bad systemic fungal infections, but you had better be ready to monitor those kidneys and electrolytes like a crazy person. You may end up with a patient whose potassium tanks after starting Ampho B, and then you get to be the one giving a whole lecture on bananas and potassium replacement. I mean, I love a good banana, but not when it's the only thing standing between your patient and a cardiac arrhythmia. Infusion reactions are another big one. Fever, chills, rigors. You'll be premedicating with acetaminophen and diphenhydramine and infusing it slowly. If you can get your hands on a lipid formulation, do it. Less toxicity, more happy kidneys. And don't forget to check those renal function tests and electrolytes, especially potassium and magnesium. Ampho B is not a casual drug. Then you've got the azoles, fluconazole, ketoconazole, itraconazole. These are a little friendlier, but they love the liver. So if your patient has liver disease, you're watching them closely. Azoles also have a ton of drug interactions. Warfarin, digoxin, you name it. And of course, you're teaching patients to look out for signs of liver dysfunction, yellow eyes, dark urine, right upper quadrant pain. If you see it, act. Oh, and nystatin for oral thrush. Just swish and swallow. Easy. But don't let them eat or drink right after, or you're just washing it away. Fungi are stubborn, and so are their meds. Tell your patients to store nystatin at room temperature and not in the fridge. It's not a dessert. Now, let's talk antiprotozoals, specifically metronidazole, also known as Flagyl. This one's a workhorse for giardiasis, trichomoniasis, and C. diff. But here's the kicker. If your patient drinks alcohol while on metronidazole, they're in for a world of hurt. We're talking a disulfiram-like reaction, aka violent vomiting, flushing, the whole 9 yards. I always tell my students, no booze unless you want to see projectile vomiting in real time. Classic side effects: metallic taste, like licking a rusty spoon, GI upset, and dark urine. Not blood, just brownish red. Warn your patients or they're going to panic thinking something's seriously wrong. You also got to watch out for nephrotoxicity with long-term use. Seizures, peripheral neuropathy, but that's pretty rare. And, of course, you're teaching strict alcohol avoidance, encouraging fluids, and monitoring for any weird neurosigns. And if your patient's on warfarin, metronidazole can increase bleeding risk, so you're definitely going to want to keep an eye on that INR. So, to wrap it up, if your patient tells you their pee is orange, their mouth tastes like pennies, and they're growing mushrooms in places they can't mention, you'll know exactly which meds to blame, and you'll smile serenely, adjust their medications, and maybe order a few liver enzyme tests for good measure. Keep your cultures clean, your meds on time, and your sense of humor fully dosed. Until next time, stay spore-free and fabulous.